Perfect. All right. Well, good afternoon, everyone, or most of you. Please bear with me while I give a generous and an appropriate introduction to our esteemed colleague here. Dr. Tward, Jonathan Tward, is a renowned figure in the field of oncology, holding the prestigious title of tenured professor in the Department of Radiation Oncology at Utah. His remarkable contributions and groundbreaking expertise have firmly established him as a major authority and key opinion leader in the treatment of prostate, bladder, and penile cancer. He's currently holding the esteemed Mancini Presidential Endowed Chair at Huntsman in genitourinary malignancies, and he's demonstrated exceptional leadership as the head of the GUC at Huntsman Cancer Institute. In that role, he actually has a significant leadership within the organization with collaborative efforts around 100 dedicated members spanning across various departments, colleges, interdisciplinary programs. His leadership drives strategic initiatives in patient care, community engagement, research, and donor relations. And he's made significant strides in advancing the field of genitourinary oncology from there and obviously on his national pulpits. He's been a physician, scientist, mentor, educator, friend to many of us just on this line. He's also been an innovator and pioneer, even prior to his expertise within the field of GU care. So here, we're privileged to have him share his wealth of knowledge and experiences with us in this enlightening webinar. So let's get started. Welcome, Dr. Tward.
Thank you, Dr. Jaboyan. That's a very, very kind introduction. It's nice to see you. It's nice to see some familiar names. And just to kind of set the tone here, I'm going to talk for hopefully only about 30 to 35 minutes, and the rest up for Q&A session. And we're going to be talking about, a lot of risk and how specifically we can use risk calculations to inform the decision on whether or not we should add ADT to radiation therapy. So I'm going to share my screen quickly here. And let me get to presenter mode here. Okay, so can someone just validate that they can see my screen?
Yeah, we can
Not
see
if
it.
you can see my screen.
Yes, we can. We're good.
We'll be talking about, how I use the Prolaris test. In full disclosure, I was the PI for several of the studies that led to the guidance on Prolaris testing on whether or not you should consider ADT use. And so when we think about ADT use in localized prostate cancer, obviously it is a primary treatment modality in combination with radiation. And we typically reserve ADT use for those with intermediate and high risk disease. But clearly ADT has lots of side effects. And I don't know about the experience of people in the room, but my experience in counseling patients who come in to consider radiation therapy is they very often have done some Google searching online and come in saying, I'm not worried about the radiation as much as I'm worried about the ADT, because indeed, it really does have a lot of systemic effects, some of which you can see on the slide. Some things that aren't on the slide, although dementia is listed, is, risk of cognitive changes in the future, heart disease, etc. But overall, it makes you feel pretty poopy. So we'd love to be very selective in who we add ADT to make sure that we're getting the most bang for the buck. And so there's clearly a recognition amongst all of us who treat prostate cancers that, kind of systematically always using it in every, let's say, unfavorable or high-risk patient may possibly be over-treating. And the only way to kind of get around how we can personalize this decision is to actually quantify the very specific benefit to the individual patient versus the risk, instead of thinking of them as a group, but really thinking of them as a person. So the NCCN guidelines, as well as virtually every other guideline, EAU, AUA, etc., have kind of similar guidance when it comes to using ADT with radiation. But if you look at the NCCN guidelines specifically, in the principles of radiation therapy section, under favorable intermediate risk, where we don't routinely use ADT, there is some guidance that says ADT use is reasonable if additional risk assessments suggest an aggressive tumor behavior. And keep in mind that NCCN risk groups don't really take into account MRI findings or molecular testing or other things. And so when the NCCN put this in, it was and PS that one really should consider when thinking about a patient holistically. And then in the unfavorable intermediate risk category, it says ADT should be used unless additional risk assessments suggest less aggressive tumor behavior or if medically indicated. I will add that's what's not on the slide in that in all high-risk prostate cancer patients, NCCN risk guidelines and most other guidelines, effectively say something similar, which is it should always be used with in select cases where you should consider omission. So for those of you who might be familiar with the Prolaris test today, you might recognize these elements on the score report. But for those who are not, let me just say what the Prolaris test is. It's actually a combination of a molecular test, which looks at cell cycle progression genes that correlates to the aggressiveness of cancer, but it also includes risk information from the age, the biopsy, the T stage, the percent positive cores, et cetera. So when a Prolaris test delivers a risk estimator, it's actually a balance of molecular information and clinical information, which is highly important to me because you wonder about, well, what if the molecular score isn't accurate or you sampled the wrong part of the tumor? Well, then you'll make up for that error on the clinical side. Or what if the Gleason score was wrong? Well, then you might make up for that possible error on the molecular side. So I think it's a very robust test in terms of risk estimation. But on the current Prolaris score report, they kind of give guidance based on an overall risk of metastasis or prostate cancer specific mortality and break men up into those who should be considered for active surveillance, those who should be considered for single modality therapy, and those who should be considered for multimodality therapy. So you'll see a kind of a view like this with a little patient icon above where, based on risk thresholds, the guidance is. But I'll also say that risk is in the eye of the beholder, which is that even though there are thresholds that are set, just like an NCCN risk group is a threshold, and an individual should really assess their own risk because it's hard for us to gauge exactly what a patient's goals are. But this is what we might see currently on a Prolaris score report. We have used the Prolaris test in my clinic, and these are really the prior studies that I've done to really kind of give very discrete personalized risk estimates regardless of NCCN risk groups. So we have two prior studies that were very large studies where we a priori pre-specified an endpoint that said approximately 30% of men with unfavorable intermediate or high risk prostate cancer should probably routinely receive ADT, but frankly, the bottom 70% might be at a risk category that you could consider omitting it. This was rationally designed, and we can talk about that perhaps later. But then we did two separate studies, two separate validation cohorts. The first was in a combination of men who had either radical prostatectomy or radiation of any kind, plus or minus ADT. Then we did a second study that was completely separate of just men receiving radiation therapy, IMRT, modern therapy, dose escalated, very clean study with or without ADT. And at the end of the day, this threshold that we established for where men should routinely always consider multimodality therapy, in other words, radiation and ADT, came out to about a risk of 8.9% metastasis a priori, based on the biopsy tissue. And the reason that number is kind of intriguing is that if you consider what multimodality therapy will do, it'll roughly cut that number by about 0.6. And we'll talk about that more. But the actual threshold, which the Prolaris score report, puts guidance on where you should move from single modality to multimodality considerations, is at about 8.9% risk based on these validations. Within see what happened to men who were above or below the threshold and whether or not they got single or multimodality therapy. So if you look at the graph on the left, the dashed lines are men whose scores fell below radiation plus ADT, et cetera. And what you can see is below the threshold, their risk of metastasis going up to 10 years is practically zero, regardless of if you treated them with a single modality or multimodality therapy. But if you were above the threshold and received a single modality therapy, you have an extremely high risk of mets at 8 years here, estimated to be about 40%. But if you added in the multimodality therapy, you could drive that risk down to just under 20%, sort of validating the utility of this threshold. And then if you look at the graph on the right, you can actually see the individual risk estimates for those who received single modality therapy, which is the blue graph, versus those who receive multimodality therapy, which is the red graph, for any CCR score. And I know that's a little confusing because I didn't introduce the concept of CCR score, but CCR score is what ultimately determines the risk of metastasis. It's that combination of molecular score, the Prolaris score, and the Gleason score, PSA, et cetera. And so you can see as that CCR score increases based on worse molecular profile or worse Gleason or worse, percent positive cores, the distance between the two graphs at any individual measure starts widening and widening, showing you that there's a greater absolute risk reduction for using multimodality therapies. So if you take men only below the multimodality threshold, you might ask yourself, well, not everyone gets the correct amount of ADT. If everyone got sufficient versus insufficient ADT, does it change anything? So again, these are all men who have below the multimodality threshold where it's indicated they should get single modality treatment. But whether they get RT alone, RT plus insufficient ADT, RT plus sufficient ADT, their risk of metastasis going out to 10 years is extremely low, basically less than 5%. So men below the multimodality threshold and the single modality threshold don't have a very significant benefit of adding any ADT. And the three separate lines are basically just stratifying out the different NCCN risk groups, which also basically show you that NCCN risk groups no longer discriminate who clearly benefits from ADT or not if you happen to be in the single modality threshold. And if you want to just kind of look at it versus above the threshold and below, you can see men with favorable intermediate risk on the left who are, by guideline standard told not to basically receive ADT. There is a subset of men. It's uncommon to be a high score here, but if you are above the threshold, you have a very high risk. And if you're below, you don't have a high risk of metastasis. Same is true of the unfavorable intermediate risk patients, above versus below the threshold. Same is true of the high and very high risk patients. It's very notable how low the risk of metastasis is in the very high risk NCCN patients who are below the multimodality threshold. So this threshold is a very, very robust stratifier of who will or will not do well. I understand I'm having a little bit of audio problems, so I might switch in a moment if the moderators ask me to, but for now, I think I will continue. So at the end of the day, those validation studies revealed that from an NCCN risk group point of view, the Prolaris test might tell you in 1 in 80 men who might benefit from ADT, but separately, the Prolaris test, which is beyond the scope of this talk, might help you decide who can get active surveillance in that population. But it's uncommon, but possible a man might be indicated for ADT. But in unfavorable intermediate risk patients, using the threshold, half of the men tested could avoid ADT. And in high-risk patients, maybe 1 in 5 men might consider avoiding ADT. So I think the sweet spot for actioning ADT based on this particular test is in the unfavorable and high-risk patients. So let's take this a step further, though. It's one thing to create thresholds. And again, thresholds give guidance just like NCCN risk groups are thresholds. But it's not really personalizing the decision per se. In some respects, it personalizes the decision. But I think that having your patient and their family in a shared decision-making sort of point of view with you go over the individual risk reductions really helps with them making a personalized decision that suits their desires and goals. So we took this work a step further, and we just presented this at ASCO a couple months ago, where we were able to not only quantify the overall risk of metastasis at 10 years, let's call it in a mixture of patients, but we used a very important meta-analysis that Amar Kashan produced called the MARCAP meta-analysis, which at the individual patient level was able to essentially establish a very precise absolute risk reduction for adding ADT to RT. Instead of just using any one trial. Like if you use any one trial, you got little complications like, oh, it might have only been intermediate risk patients, or that trial might have only been high risk patients. But the geniusness of Kashan's meta-analysis was that it used numerous prospective randomized trials that looked at the addition of hormone or not to radiation or the duration, and came up with what is probably the best level 1 evidence estimator of the absolute risk reduction. And I'm not going to go over this poster here. It's too much to go through. But what Kashan effectively found was that no matter what patient walks through your door, no matter what NCCN risk group they are, if you add at least short duration hormone therapy to ADT, you'll always get a hazard ratio or risk reduction of about 0.6 on a metastasis risk estimate. So how do we use this information with Prolaris to now alter the guidance in the score report to be more useful? So we did it in several steps. Step 1, you estimate the risk of metastasis if you only give single modality radiation. That's critical. If you only give single modality radiation. And this is where the Prolaris test has a heads up on some of the other tests out there. The other tests do not restrict their risk estimates to people getting just single modality radiation. Their risk estimates are jumbled up with people who got hormone therapy or didn't, or surgery, etc. Then you estimate the relative benefit of ADT added to RT that is derived from the MARCAP meta-analysis. Then you can calculate the same risk using MARCAP. And step 4, you can calculate the absolute risk reduction, which gives you a highly personalized estimate. So what we did was we combined patients who got single modality therapy from the first 2 validation papers and came up with 467 patients that only got single modality radiation therapy. And we could derive a 10-year risk of metastasis risk curve, as you can see here on the right, based on their CCR score, which again is the combination of the clinical factors and the molecular factors. You can see as the score increases, the 10-year risk of METs also increases. And that dashed line that goes vertically at about 2.1 happens to be where the multimodality threshold is set. So you can see again that that threshold is set at a 10-year risk of about 8.9% if you receive single modality therapy. So I can probably skip over this slide because I mentioned it, but the Kashan meta-analysis used thousands of patients to derive their hazard ratio of 0.59. And so here you can see how you can model the data. The figure on the left is men who get single modality radiation. The green line shows that. The blue line shows how their risk would be altered if they got ADT based on the MARCAP meta-analysis. And then the graph, sorry, I should have said on the left, the graph on the right translates that. The scale on the left side of the y-axis shows the absolute risk reduction. That's the most important thing. So if you look at, for instance, the threshold at 2.1, if an individual happens to have a Prolaris score at precisely that point, their absolute risk reduction may only be about 4% by adding ADT. And if you look at the y-axis on the right of the graph, that translates to a number needed to treat exceeding 25, meaning that you would have to give 25 patients that treatment without any benefit for one to benefit. Whereas if you look at a higher Prolaris score, let's say they had a CCR score of 3, you can see there that the absolute risk reduction would now be about 10% by adding ADT. And now it moves down to you only need to treat 10 patients for one person to benefit. And I think it's a very powerful thing to describe risk to patients in terms of number needed to treat. I think that maybe physicians who've gone through through lots of math and training, have a easier time understanding a hazard ratio, maybe an absolute risk reduction. But I think that number needed to treat is explicable to almost anybody at any education level. So, if you tell somebody I'm going to treat 19 patients needlessly for one to benefit, I think even somebody with, a 6th grade education could probably wrap their head around that. And this just kind of describes how the calculation is specifically made. So if you look at the specific threshold, this particular patient with a score of 2.1 would have a single modality risk of 9.2% Mets at 10 years. It would be 5.5% if they added ADT. Their absolute risk reduction would only be 3.7%, translates to a number need to treat exceeding 25. Okay, so how do we package this all together? You have a test that sets thresholds for active surveillance or single modality. And at this, if a man happened to have a precise risk at the threshold, like they had a score that happened to be precisely a CCR score 2.1, their absolute risk reduction would only be 3.7%. If you look at the entire population of men in the single modality threshold, if you take all the commercial testing, 15,000 patients, et cetera, and say, on average, this group, what is their benefit by adding ADT? As a group, everyone below the threshold has less than a 1% absolute risk reduction. Number needs to treat greater than 100 patients. I think no person would likely choose ADT if they knew that was their cohort risk. Whereas if you take all the patients above a multimodality threshold and look at their absolute risk reduction, that would be about 8.2%. So now we have a lot more information than we did previously. So the Prolaris test does in fact provide a very consistent and double validated model for the multimodal threshold, which helps in a general sense guide who you should routinely consider ADT for and who you should routinely consider omitting it. But at the moment, it's the only biomarker that provides this highly personal risk estimate of absolute risk reduction so that the individual can really decide, regardless of threshold, whether using or omitting ADT is probably right for them. And because it translates this into a number needed to treat, I think it makes it very easy to communicate this to a patient. So based on this set of work, Prolaris recently released a new version of the score report. So I'm just going to walk us through how this score report kind of looks to see, how one might use it in clinic, how I would use it in clinic. So we'll start with the first page. This is a patient who was 63 years old. His PSA was 6.2. He happened to have T1 disease. He had more than 50% positive cores. His Gleason score is 3+4. So he's an unfavorable intermediate risk patient by NCCN guideline, but he has a low PSA. He has a low T stage. He has a low Gleason. It's really the percent positive cores that kind of kicked him into the unfavorable intermediate risk category. He had a so-called Prolaris score of 3.5. I want to be clear, that is not the CCR score. But when you combine those clinical risk factors with a Prolaris score of 3.5, you throw out the risk estimates that you see on the slide below. First of all, he has a 4.7% risk of dying of prostate cancer in the next 10 years if he didn't ever receive any curative intent therapy, although that's not what we're going to focus on here. But if you look at the single modal part of the graph, which is, again, you're seeing these patients a priori before they receive surgery or radiation. This risk estimate below, this 3.1% that's a little grayed out, is regardless of your decision of surgery or radiation, we think your risk of metastasis in the next 10 years is only 3.1%. But if you were to receive multimodal therapy, that multimodal radiation and ADT specifically, that's only going to go down to 1.9%, a very modest change. So on the second page of the score report, it kind of is very clear and quantifies it and says, in this particular patient, if they chose an RT path and they chose to add ADT to RT, it's only going to drop their risk of Mets at 10 years by 1.3%. And maybe not so easy to see in the smaller print at the bottom, that translates to a number needed to treat as 78 persons. Now, I will tell you that in my clinic, if I told patients I can add ADT to your RT, but 78 persons are not going to derive any benefit for one to benefit, the vast majority of patients would choose to omit it. The vast majority. And keep in mind that this patient, by guideline, is told to get short-term ADT. So let's pause here, and I apologize if my audio was choppy, but let's see if there are any questions. I'm happy to take questions.
Hey, Jonathan, it's Bridget. And you know me, I can't ever not hold back can't ever hold back my question. So how often are you actually using Prolaris in your clinical practice? Are you ordering this test? Is it coming from other places? Or how often are you just using your clinical judgment minus biomarker testing in your recommendation?
That's a great question. So I will tell you that, frankly, and I guess this is part of the, I've done the 3, pivotal studies looking at the use of Prolaris and RT. So I'm a true believer. So my answer to the question is this: the only intact prostate cancer patients I do not order this test in, the only ones, are those who have Gleason 9 or 10 disease, or those who have seminal vesicle invasion. In other words, NCCN very high risk patients. I feel that those patients always deserve multimodality therapy. And in fact, sometimes I'm wondering about even further escalating with an ARAT. So what's interesting is I use this test in everybody else because I'm often making active surveillance decisions in the very, in the favorable and risk patients. But if you look at the area under the curve for this test, which I didn't present because it was beyond the scope, which is, in a way, if you look at NCCN AUCs versus Prolaris AUCs, at how good is this prognostic model? This prognostic model is consistently at an AUC of 0.8, whereas NCCN as a risk stratifier might only be around 0.6 to 0.65. So I personally feel that on biopsy specimens specifically, that this is the best test out there, and I use it in every single guy with intact prostate cancer except the ones I mentioned, and I action it every time.
I had a question from the chat from Dr. Wilkinson. So
I see that
the CCR score also on the Polaris report.
So I do not believe that the CCR score is written on the Prolaris report. You can derive it. I've actually encouraged Myriad to put it on the report somewhere. And maybe it is there in a small print somewhere, but it's clearly not highlighted. You can actually derive it yourself. Not that anyone wants to do math when they order a test, but it's 0.39 times the Capra score plus 0.57 times the Prolaris score, and it can spit it out. But I think it's an esoteric number that's not useful unless you're really on the research side. What's really useful is how it translates to the risk. And I see another message in the chat. How long does it take for results to come back? For me personally, it typically takes about 2-ish weeks from the time I order the test to get the score report. So it's not a very long delay. I actually have a system in place in my own clinic where when a consult request is made, we actually send in the test request so that hopefully and then we don't set an appointment for about 2 weeks so that I have that information available to me. My front desk is very good at knowing not to order it in Gleason 9s and 10s and T3Bs, et cetera. But that's my strategy. It goes to Bridget's question. I order it in almost everybody, and I want that test result on hand So you could expect about a 2 to 3 week turnaround. Let's see. I see another question in the chat. How does Prolaris compare to Decipher? That's a really great question. So I think Decipher is also a very good risk estimator. And I think that these are the nuances that you have to understand about the two. And so another way to say is like, why do I prefer Prolaris over Decipher? Well, I think for the following reasons. First of all, Decipher was rationally designed in the post-prostatectomy setting to look at biochemical failures. So you have a biomarker that was created to answer those questions. And then later they sort of validated it in the biopsy setting. And it works at prognosticating biopsy. But the concerns I have with Decipher are the following. Decipher's guidance will say at a Decipher score of above 0.6, you should consider therapeutic escalation. So based on their purely molecular score alone, they set a threshold 0.6. But if you take a man with 0.6 Decipher who happens to have favorable intermediate risk disease, Decipher's own 10-year risk of metastasis is only 2.5%. And that's in a mixture of single and multimodality therapies. And I'd say 2.5% is so low that I'm not sure the guidance on the score report should always be just because he's at 0.6 that you should escalate. A guy with unfavorable intermediate risk, same exact Decipher score, 0.6, has a risk of 5%. And a high-risk guy, same exact 0.6, 7.5%. So I feel that the Decipher score is a little bit confusing because it's mixing up how it uses the clinical information, number one. And the second thing I'd say is that those risk estimates that the Decipher score provides are, again, not restricted to men who've had single modality therapy only. They were derived from mixtures of men. So it's almost impossible to know how adding ADT would actually shift that estimate. And so that's why I prefer personally Prolaris for biopsy, but I know a lot of people use Decipher, and I'm just glad when people use some kind of risk estimator. Like if you could use a nomogram, you could use Decipher, but using something is better than an NCCN group alone. So let's see. Other questions. Any issues with insurance coverage? Usually not. When I order a Prolaris test, by the way, it's not something that your front desk needs to manage, but my experience with it is they do whatever authorizations, and if there is a problem, I think they get back to you. But I have not routinely had any trouble with insurance. Maybe before I go to the next chat question, let's see if there's a live question, then I could get back into the chat. Is there a live question? Okay, there was a question in the chat that was saying, if they understand correctly, CCR is a factor of the CAPRA and the molecular score, not anything else. I've wondered, since the order sheet has us fill out prostate volume and race, if those were included. So that's a good question. You are correct that the CCR score is purely CAPRA and molecular, does not consider race, it does not consider MRI findings, it does not consider PSA density. However, I will say that there was a publication at least speaking to race. We included patients from the Ochsner Clinic, and the Ochsner Clinic is in Louisiana, has a very high ratio of African-American patients. And so in these studies that we looked at, we had a very significant way to look at that. Maybe up to 20% of patients were African-American. And there are other publications using Prolaris that show that at least African-American heritage versus the test as a whole is not significantly different. So it does appear that this particular test would be different, at least for African-American patients. I don't know of evidence that looks at other ethnicities. And PSA density, if I look at that, I think is a more validated biomarker for surveillance versus active treatment. It's not clear to me that PSA density has been as clearly looked at in whether or not you should use multimodality versus single modality, whereas, you know, percent positive cores has been looked at a little bit more in that setting. So let me see, there looks like there's a new question. I'll give it about 10 or 15 more seconds to see if there are other questions. If there's not, I could run through a couple cases that we've prepared here. So any other questions before we look at a few cases? All right, looks like we can do a few cases then. All right, so this is the case that was just sort of presented, and maybe we can dive a little bit deeper into the score report. We kind of went over this aspect of the test. I want to again be very clear on this page of the score report that single modality risk estimate, 3.1%, is for either radiation therapy or surgery. Okay, and so when you look at the absolute risk reduction using ADT with radiation on the second page, there might be a very small shift in what you might, if you look at these two numbers, 3.1 minus 1.9 is 1.2%. But on page 2, we nuance it specifically for patients who get radiation. So here on page 2, this particular patient, again, he has a 4.7% risk of disease-specific mortality if he underwent conservative management. Now, the threshold there is at 3.2%. This is worth sort of talking about. And again, this is not metastasis, this is death. So the Prolaris test was designed to be a biopsy-specific test, which is, again, why I bias its use in my patients. It was designed on biopsy tissue to prognosticate metastasis and death on biopsy tissue. And that original study that led to that 3.2% was from a large UK cohort that was conservatively managed, and it was in an era that maybe wasn't as well PSA screened, etc. There was a second study that was published that showed that in a United States cohort or a more modern cohort, that if you're at that threshold, that 3.2% in a more modern cohort, your risk of death at 10 years was actually 0% if you did active surveillance. So I think that threshold is very fair, because I'd argue even a 3% death is something that maybe someone should consider treatment, but in the PSA screened more modern cohort, that risk is actually lower. So again, I order Prolaris tests. Hopefully I'm not seeing a lot of low risk patients. I hope a lot of urologists aren't sending those to me. But I order it, and the utility in a low risk patient and in a favorable intermediate risk patient is in me determining really this active surveillance threshold. But going down to like the next box, okay, if you use single modality radiation, this guy's at 3.1%. Most of us would agree that's low enough. We're probably going to go single modality. And if you added ADT, you're only going to drive that number down by 1.3%. So let's look at a different patient, though. So here is a different unfavorable intermediate risk patient. This guy's 65 years old. His PSA is 6.2. He's a T2. He has 34% positive cores, but his Gleason score is 4+3. So he also has, he automatically buys unfavorable intermediate risk for the Gleason 4+3, but that Prolaris score of 4.9 is actually rather high. I guess to talk about the Prolaris score component, which is the purely molecular component, on average, if you take all comers who get tested, an average Prolaris score is about 4.0. And I'd say something like 75 to 85% of patients will fall between a range of 3.5 and 4.5 on their purely molecular score. So 4.9 implies some pretty aggressive molecular features. And so when you look at the risk model below, you can see that this guy, if he was conservatively managed based on the older UK cohort, would have about a 12% risk of death, pretty unacceptable. But if you treat him with single modality therapy, whether that's radiation or surgery, he still has a 13.5% risk of metastasis in the next 10 years. That's a very high risk of mets. But if you were to combine ADT and RT specifically, that number would be driven. So K moving right along to the bottom, his is, which means number needed to treat of 18. And if you polled most patients, both experts and patients alike, because I did this and we published this, Dan Spratt and I polled the NRG-GU steering committee, at what absolute risk reduction would you personally take ADT in? Basically, the threshold for 80+% of experts was at a number needed to treat of 20. It had to be 20 or less. Only 20% of experts would throw in ADT for a number needed to treat exceeding 20. Okay, so, but also when Dan Spratt tweeted this out to the Twitterverse as a poll, the lay public or whatnot, or whoever's following the Twitter results, also chose kind of the same threshold. So this is very consistent with both patient attitudes and professional attitudes. And I'll get to the question in a moment in the chat. I see it there. So let's see. The question in the chat was, let's see, would the genomic score be different on random biopsy versus an MRI-guided biopsy of a dominant lesion on the same patient? And also, would the genomic score be different on a biopsy of a patient at initial diagnosis versus repeat 3 years later after active surveillance? So let me take them one at a time. So when one orders the Prolaris test, what happens is the pathologist at Myriad requests the tissue from whatever place has the tissue. And then a pathologist at Myriad will look for the dominant area of cancer on the slides, and they'll dissect that area specifically. So just to talk about how Myriad chooses which area to evaluate, that's how they do it. And generally speaking, the largest cluster of cancer on the slide is almost always the dominant Gleason score. So I think, but the question really kind of was, would an MRI guided biopsy be different? So when MRI guided biopsies are sent in, they'll do the same thing, but they'll really probably just take the MRI evidence, like a study that looks at random biopsy versus MRI, but presumptively the MRI is probably the dominant lesion and would be the area that might have been tested anyway. The problem with MRI only biopsies is that if they also didn't get a standard sextant biopsy, you cannot calculate the percent positive cores accurately. In other words, you cannot take an MRI guided biopsy that shows 3 or 3 cores and say, oh, that's 100% positive biopsy. That will mislead the CAPRA score, which will mislead the risk estimate. So what I do, which is, I'll call it not very validated, but how I deal with a patient who only has an MRI guided biopsy, which I think is a bad practice, by the way. But if a patient only has an MRI guided biopsy, I will always, on the Prolaris order, tell them that it's 1 out of 12 cores, because the NCCN itself says you should treat all positive biopsy cores from an MRI biopsy as 1 core, regardless of how many. Now, I know that might fudge the numbers a little bit, but that's how I deal with that. I also encourage patients who get MRI only biopsy to actually get a sextant biopsy. So hopefully that answers the first question. The second part of the question would be, does it change if you repeat biopsy? My answer anecdotally, and I should probably publish this paper because I now have hundreds of patients where this is done. The answer is yes. When I repeat biopsy a patient on active surveillance, I send in a second Prolaris, and often I will see some change in the molecular test, but it's frankly pretty minor. Like there might be a very subtle change, but anecdotally speaking, I have not personally seen big shifts in Prolaris scores. Usually the difference is in Gleason or percent positive cores, which is kind of what tips the risk estimator. So none of the companies, Decipher, Polaris, anybody, have ever published heterogeneity papers. It's something we're really interested in knowing. Like if you were to test one tumor versus another tumor, how much heterogeneity is it? We don't actually know the answer to that question. It's a study I would love to do. The problem is the expense of doing that when you don't have company support. So let's see, we have about 12 more minutes. I'm going to give 10, 15 seconds to see if there's another question. If not, I can maybe throw another case, maybe not. Or Dr. Jaboyan or others, anything that you feel?
No, this has been great. I think another case, we have some time.
Yeah, actually, I might not have another case.
Oh, I see.
I don't have another case. I will say something interesting, maybe as I'm waxing poetic in the last few minutes. Something that's not on the Prolaris score report, but I think is really interesting to note. It's published in one of our validation studies. It's published in the first validation study, is if a patient gets radical prostatectomy and they're above the multimodality threshold, by about 5 years, their chance of biochemical failure is something like 45%, okay, if they're above the threshold. Whereas if they're below the threshold, their chance of biochemical failure is maybe only down at like 20-ish%. So when I'm counseling a patient and I have that score report and they're above or below the threshold, and they're still pondering a surgery versus radiation pathway, I kind of say to them, hey, I'm truly not against surgery. I think surgery is a great choice for lots of men. But I think surgeons will often tell a patient, you could always do radiation after surgery easily, but not the other way around. That's true, but the argument is maybe a little specious if you don't say, but your odds of getting a recommendation for salvage radiation above this threshold is almost 1 in every 2 patients, right? Whereas the probability that you're going to be recommending an additional local therapy in a guy above the threshold who also receives ADT is way lower than 45%. So I think that it helps inform the decision on what is the probability that somebody might require salvage radiation, even though that's not really on the score report now. It's something that you could look at in the original paper, and something I've encouraged the folks over at Myriad to consider adding to the information, like what are the odds that you'll need, salvage radiation after surgery. So that's an additional kind of pearl in how I use it clinically.
The great pearl.
Okay, looks like I got some other questions that I can see. How do I talk about number needed to treat with patients? I've sort of discussed that. Do patients understand the concept of absolute risk reduction? I mean, I think they do, or they can. Again, I like to lean on number needed to treat more than absolute risk reduction. I give patients all the numbers. So, when I actually talk about risk with a patient, I really say everything. I say adding hormone therapy to radiation will reduce your risk of metastasis at 10 years by about 40% total. But I'm like, that 40% risk reduction doesn't matter if your risk is only 1% at 10 years, right? So then I go say, all right, so your odds, if I treat you with one simple thing, and that's the term I use, one simple thing, a surgery alone, SBRT alone, an implant alone, might be, in the case of the patient we had here, 3.1%. And then I'll say to him, okay, that's already so low that any of those treatments are super reasonable. So let's get into the discussion about side effects of each. But I don't think we really want to talk about adding ADT here unless you want to have an absolute risk reduction by adding in ADT of 1.2%. Like if that's what you want, fine. Let's talk. There, but because that number needed to treat for you, sir, patients are going to have hot flashes, decreased sex drive, potentially cognitive problems, risk of stroke and heart attack, blood sugar control issues, mood disorders. Like, are you game for that on a number near 2 to 78? And again, most patients would not go for it. Whereas most would go for it again on a number near 2 to 20. But experts, about 2% of the experts said they do it for an absolute risk reduction of 1%. And I'll also say that about absolute risk reduction was 10%. So it's pretty interesting. Experts can't agree and patients can't agree. If I had my preference, the world according to me, I would like every single prognostic test, whether that is a nomogram, a molecular test, an AI test. I think the critical utility in talking about quote intensification versus de-intensification is very specifically quantify those benefits. And right now, the only way we can do that, at least for ADT at the moment, happens to be with this particular test because Myriad has chosen to do the studies with this particular test and restricted the analysis to single modality radiation therapy specifically. So we can answer that very question specifically on the biopsy in men pondering RT. And until the other nomograms and prognosticators do that, it's hard to compare these tests to them. They don't have that utility yet. There's a question in the chat. How hard is this to order? Online available? Boy, I'm embarrassed to say that I don't know if it online's available because my front desk does it for me. I know it's relatively easy. And maybe somebody from Myriad can maybe throw me something in the chat or answer that in the chat. It's a simple test. I think we might use a fax form actually. But you just fill out basically, where's the lab that has the tissue, and Myriad handles it. And you just put in some basic information so they can calculate CAPRA, the Gleason score, the cores, the age, etc. And I guess it's simple because someone else does it for me, but they don't tell me that it's hard. I'm seeing in the chat that online ordering is not currently available. There appears to be an email option, but I don't think it's a very big impediment. Like ordering it right now doesn't seem to be very hard for my clinic. And it's actually a job that, again, we trained our front desk to do. There might be front desk people who don't want to dig into the Gleason score on the score reports. And in that case, I think it's an excellent job if you have PAs or scribes or residents. That might be a good task for them to help you out so that you don't have to do it yourself. But it's so trivially simple. I don't think it really slows you down.
Hey, Jonathan, this is Ben Wilkinson. Finally got a microphone. Thanks, a great presentation. I had to step away for a second, so I didn't hear the post prostatectomy radiation recommendation, how you use the score. And I heard that you may have recommended it might get added in the future, but do you mind just briefly saying that again of how you guide men who are thinking about prostatectomy with Prolaris?
Yeah, so it's not on the score report, but this information is detailed in our validation publication. Basically, if you're above the multimodality threshold, the group of patients who choose surgery who are above the multimodality therapy, above the threshold, as a group, they have a 45% probability within 5 years of having a biochemical failure. Therefore, I would say that roughly 1 in 2, we're going to be having a discussion about salvage radiation. So whereas the men below that threshold as an entire cohort only have a risk of about 20-ish%. So again, we're seeing these patients before the treatment decision is made, and it helps inform the discussion on whether or not they might want to consider surgery radiation. Because again, the surgeons usually tell patients you could always get radiation after surgery, but not vice versa. But they don't tell the patient, oh, by the way, 50% of guys above this threshold are going to have that discussion with the radiation oncologist, right? So whereas men above the multimodality threshold that we actually treat with multimodality radiation therapy do not have a 45% chance of getting additional therapies. They have a much lower chance of that. So I lens the whole discussion of surgery versus radiation in general of, do you want to front load therapy? If someone's above the multimodality threshold, the way I think about it is, do you want to front load therapy by kind of throwing the book at you all at once? Hormone therapy, probably nodal radiation, and treat the primary? Or do you want to ponder this like a sequential approach? If you do surgery, you're selecting a sequential approach. Like, all they're going to really get is the prostate gland. They're not going to very effectively get all the lymph nodes at risk. But if you have a recurrence, then I'm going to throw in, radiation of the fossa, but now I'm making other decisions about hormone therapy and or nodal. And in that case, I actually use decipher, because again, I'm picking the test that I think is the best validated for the data at hand. Like in biopsy tissue, a priori, there is no doubt in my mind, this is the best test currently. There's also currently the best evidence in the post-prostatectomy setting. If the guy's already gone and had prostatectomy, I like decipher because you've got, data from RTOG that shows, high decipher scores below PSA 0.6 stratify men into who does or doesn't benefit from ADT. And now you have an AI test from Artera that in intermediate risk patients might be able to stratify who does or doesn't benefit from hormone therapy, period, but doesn't prognosticate, but it won't necessarily give you the single modality therapy prognostication. So again, you have all these tests out there and they all kind of have a niche. And again, I'd much rather someone get some kind of test or use a nomogram to inform the decision. NCCN guidelines alone is not a good way to go. I remember Jim Moeller, who used to be the guideline committee, he said publicly, "You're not a very good doctor if you always use our guideline to treat a patient." And I think that he might have also said, I'm not sure it was him, probably something like 80% of patients should be treated to the guideline standard, but probably 20% of patients, you really need to nuance this decision, right? Based on what does the MRI show? What does molecular testing show, et cetera. So I've run out of time. There are additional questions, but I'll leave it to the moderators to decide on if I should continue.
Let's just, there's any future Polaris research coming?
There sure is. Yeah. So yeah. Well, there's things I'm trying to do. The company has been, for me, very great to work. I'm trying to Prolaris test tissues from NRG, look at how Prolaris performs specifically in level 1 data, for instance, in the post-prostatectomy setting from like the SPORT trial. I think it would be very useful to see if the test can help you with those nodal plus or minus things, ADT plus or minus. It would be nice to have that level 1 evidence. I also would love to get data out of RTOG 0815, which is plus or minus short-term hormone therapy, to see again in a level 1 evidence-based way. There's some other really cool stuff that I guess was presented that we're gonna validate. There was a very nice paper that came out of not University of Michigan, but there's a group of residents, and I apologize that maybe it was Michigan residents. They showed that in a small group of patients, it was highly prognostic for determining lymph nodal metastasis after prostatectomy. So we're now doing a larger study that is validating that. And so I think, like, stay tuned for those things. I think the more things we can prognosticate with one single thing, it becomes even more and more helpful again. And this will be on biopsy, it'll basically be on biopsy tissue. Can you prognosticate who has lymph node metastasis, which again is a useful thing, which I think could guide a surgeon on should they do an extended nodal dissection, and also guide a radiation oncologist on nodal fields. So that's kind of where my personal research program is headed.
Fantastic. Well, thank you again so much for this presentation. Educational, enlightening, practical, wonderful.
It's my pleasure. I hope you all found it useful. And if there's one thing you end up doing after this talk, it's do something more than NCCN guideline. Do something more, and pay attention. Those tests are much more prognostic than any stage or risk group. Thanks again.